How much time should I give for people to do the polls, or should I just keep talking?
We can we'll help run that for you. We have a
Okay,
sense of how that is.
sounds good.
Welcome back, everyone. I'm going to let Ken introduce himself and his discussant. And so great to see you guys in each of the rooms working through these problems.
All right, everybody, let's get started. Thanks for having me for this Thursday session. I'm going to do MKSAP review Pulm sleep, as you notice in the questions, and we'll try to get through as much as we can. And so as me, I work at the VA. I did my training here in internal medicine and sleep, and I've been on staff at the VA ever since. I did spend a couple of years away at the Pittsburgh VA and I came back. Most of my responsibilities are seeing patients and precepting trainees, and I do have some administrative duties running the sleep clinic at Puget Sound and also the Walla Walla VA telesleep program. Okay, I'll let Tom introduce himself.
Hey, I'm sure many of you know me, but Tom Keller, I'm one of the pulmonologists at the University of Washington. I primarily do lung transplantation now, but my interest is primarily in quality improvement, and we're currently working on some lung transplant quality improvement projects if anyone's interested.
Great. And one disclosure, I do write items for the ABIM sleep medicine boards, but not specifically related to this. I think based on their stipulations, I'm allowed to give this talk. Anyways, we'll skip ahead. So just to real quickly cover the blueprint, I think that the bolded parts are the ones I've picked questions from. I try to identify questions from MKSAP where there was a low correct response rate or some debate on what the right answer is. So we got 9 questions to work with. I couldn't cover every single section. And then the objectives we'll actually skip for the sake of time, and we'll cover those on the questions. Okay. So we'll start with the pulmonary section. So this is in line with the order of questions that you have on your handout. And I'll just read this to you. The first question: 72-year-old man hospitalized for progressive dyspnea and cough following a sore throat 3 weeks ago. Medical history significant for IPF, diagnosed 4 years ago, requires 2 liters of oxygen at rest. And he's pretty sedentary disabled because of that. And he's on pirfenidone, it's a treatment for IPF. And on exam, he's hypertensive, his pulse is 105, the respiration is 28, saturation is 89% on 6 liters of oxygen. And he's got diffuse inspiratory rails in all zones that are worse at the bases. And he's got some clubbing and a little bit of edema, but no JVD. And there was a BAL done that was positive for rhinovirus, and his BNP is 20. The high-res CT scan demonstrates new ground glass opacities on a background of basal predominant septal line thickening with traction bronchiectasis and honeycomb changes. CT angiogram demonstrates no PE. Okay. So which of the following is the most likely diagnosis? See the poll pop up. Oh.
Are you guys seeing the results?
I see them. I don't know how many have answered, though. I see the percentage.
Yeah, that we'll use this.
89% answered A, 11% answered B.
Okay, well, you are a smart bunch, and let me advance my slides. That's the correct answer. A is the correct answer. Based on the MKSAP tallies, 55% got this one correct. So let's talk about the choices and where mistakes could have occurred. And I guess my question would be, how does one distinguish between different types of ILD by presentation and imaging? I'll do my brief thing, and here I'm going to pull Tom in to help me discuss this. And well, do you want to just jump in based on the info I provided here?
Yeah, so honestly, I find the diffuse parenchymal lung diseases to be quite confusing, particularly given that the patterns on imaging are not necessarily specific to any one diagnosis. And the reason that I say that is that the most common pattern that we see on imaging is something called usual interstitial pneumonia, which is this lower lobe predominant honeycombing traction bronchiectasis. And that can be seen in multiple of these categories. So the diffuse parenchymal lung diseases of a known cause, for example, drugs, rheumatologic disease, can present as usual interstitial pneumonia. IPF, the hallmark pattern, is usual interstitial pneumonia. And then the other interesting thing is that it's estimated that about 30% of patients who are diagnosed with idiopathic pulmonary fibrosis actually have chronic hypersensitivity pneumonitis that is fibrotic. So while we say that there are specific patterns on a CT scan that can be helpful, that is true, but it can also be very confusing. So I would say that the history probably is the more important aspect that helps you point towards one diagnosis over another. And I think in this case, the history really points towards this being idiopathic pulmonary fibrosis with a secondary exacerbation.
Got it, because they didn't provide any history of sort of allergen exposure.
Exactly.
Right, for the second highest choice. And I'll back up here. And then, and I think, well, I have some images to sort of help distinguish, we'll try to distinguish between choice A and choice D, where the choice D being the second most common choice. So we ruled out, well, we know it's not heart failure based on the history, that's pretty clear. And then the acute hypersensitivity pneumonitis, that wasn't given really in the history either. And then so looking forward, I guess I'll kind of pimp you a little bit, put you on the spot, Tom. You said it's very hard to distinguish. There's no clear one pattern on imaging. I guess I will kind of quiz you a little bit on this imaging pattern. Can you comment on what you think it could be of the three, like hypersensitivity pneumonitis, UIP, the usual interstitial pneumonia, which is typical of IPF, or the non-specific interstitial pneumonia?
Yeah, so the images that you have here are actually one of the more specific findings if you were to take a board exam of chronic hypersensitivity pneumonitis. And what makes this most consistent with chronic hypersensitivity pneumonitis, if you look at the coronal image in the lower right-hand corner, the pattern on that imaging is what is described in the radiological literature as head cheese sign. Head cheese is a mystery meat that is a combination of like collagen and an actual meat and fat. And when you look at a cross section of it, there's like darker areas, which would be the normal lung in this image. There are the fat chunks, which are the great, John. Yeah, head cheese is disgusting. The fat chunks that are solid nodules, and then the ground glass are sort of the lighter parts of the head cheese. And that is classic for hypersensitivity pneumonitis. And what you can see in this lower image, I don't think my pointer's showing up on the screen, but
I'll do it for you.
You see darker areas, which are areas of air trapping on the expiratory image. You see normal lung, which is the sort of hazier area on the expiratory phase imaging. And then you see consolidation, which is the really white areas. And that is classic for hypersensitivity pneumonitis. And if you see that, you have your diagnosis. But as I pointed out, this is not this is not sensitive for hypersensitivity pneumonitis. And some patients with more advanced hypersensitivity pneumonitis will have just fibrosis, and you will
I
not
see.
necessarily see this pattern.
I see. Yeah, so that's what they commented on, is the air trapping was most helpful. And I guess the great explanation with the the food corollary. Here's one more image, still relating to our question. Can you help distinguish which side of the image is UIP and which side of the image is NSIP?
Yeah, so as we talked about the hallmarks of usual interstitial pneumonia, and I think you get to this on the next slide, but the hallmarks of usual interstitial pneumonia on the ATS guidelines are 4 criteria. And the first thing, and you can't really see this on this image because it's just a single cross section, but the first thing is that usual interstitial pneumonia is a basilar predominant process. And although it can involve the apices, there is a gradient, and it should get worse as you go further towards the base of the lungs. The second thing is honeycombing. We recently changed the diagnostic criteria for honeycombing. We used to require 2 rows adjacent to one another to make the diagnosis. Now we only require 1. And honeycombing is essentially thick-walled cysts that, and it requires 3 of those thick-walled cysts to be adjacent to one another. And then it does not spare the subpleural space. So it has to be right up against the pleura in order to call it usual interstitial pneumonia. And then the final thing is traction bronchiectasis, which is essentially airways that appear larger than normal as you get out towards the periphery of the lung. And it is because of the fibrosis. The fibrosis is actually pulling those airways open, hence the traction part. So that left image that Ken has graffitied is most consistent with usual interstitial pneumonia. And based on that one image alone, I would call that definite UIP based on that image.
Got it.
Now, the right image is potentially more consistent with non-specific interstitial pneumonitis. In that right image, you don't really see any honeycombing. Those thick-walled cysts, 3 in a row, you don't really see any of that in that image. And what you're predominantly seeing is ground glass and a couple of micronodules. And when you see that, that's most consistent with non-specific interstitial pneumonia. Now, I will say that I don't necessarily agree with what's written on the slide here, in that it's subpleural. The classic board answer, if you were to be asked about non-specific interstitial pneumonia, is that it spares the subpleural area. There should be a thin line of normal lung tissue immediately subpleurally, and the ground glass is then adjacent to that or more medial in the lung.
Got it.
That being said, it can involve the subpleural area. But if you're going to be asked about it on a board exam, I would say that there is subpleural sparing. That is like the hashtag if you're asked about NSIP.
Got it. So right along that, right where that pointer, well, let me show my pointer. Right around here should be a strip of normal lung, and then the fuzzies next to it. Yeah. Okay. So this is just kind of everything we talked about. Again, there's no, I guess, one thing on the image that would say it's this versus that, but there's features of image findings that point towards one versus the other. Okay. All right, let's move on.
And I guess the final comment, I don't want to spend too much time on this, but the final comment I would make is that although UIP can be seen in multiple different disease processes, chronic hypersensitivity pneumonitis is a very specific pattern, and the history should lead you towards an exposure. And if somebody who has an acute exacerbation of chronic hypersensitivity pneumonitis, they should have a repeat exposure, or that they had some sort of outdoor activity or some sort of indoor exposure that triggers the event. And then if you're seeing NSIP, although there is an idiopathic form, almost all patients with NSIP pattern have a rheumatologic lung disease. So you should get a history of some other sort of rheumatologic picture.
Got it. Great. Thank you. Okay, going on the next question. So question 2, 62-year-old woman evaluated their ED for worsening dyspnea on exertion during the past 2 weeks. She has a history of severe COPD, FEV1 of 45% of predicted. She's coughing of yellow sputum, wheezing. She's a 20-pack year smoking history, but quit 10 years ago, and using albuterol, not getting much relief. Current medications are umoclidinium and vilanterol, mometasone, and albuterol. On exam, temperature is normal. Blood pressure is 132/64, and her pulse is 110. Respiration 30 per minute, saturation 90% on 6 liters of oxygen by cannula. She's tachypnic, tachycardic, using accessory muscles, and there's some decreased breath sounds throughout with a prolonged expiratory phase and expiratory wheezes. No JVD or edema. The labs show a arterial PCO2 of 46, and the rest of her labs are normal. Chest X-ray is hyperinflated lungs, flattening the diaphragms, no infiltrate. Okay. And which of the following is the most appropriate next test? Okay, let's see, 94% answered A, 6% answered C. Okay. And the correct the correct answer is actually a ECG. 21% correct. So I got this one wrong too. I picked A myself doing the MKSAP. So let's talk about this a little bit more. And I like to, well, I think I'll kind of just go through these 2 slides, and I like to get Tom's take on this. I mean, just reading through the reasoning, the rationale, I think, well, yes, that you should think about ruling out PE, but try to use a decision algorithm to assess the likelihood of this person having PE. So, all right, so we'll apply the PERC rule and see what kind of points we get. So I scored this patient. We got 3 points because I think it's a 62-year-old woman who's tachypnic, tachycardic, and sitting on oxygen. And so you got to move on to the next step. You can't rule it out for PE using PERC. And then you apply the Wells. Interesting chat room. And then, so if it's less than 2 points, it's a low risk group. So I suppose this person got 1.5 points just for the heart rate. Everything else was negative. So I suppose you could call it a low risk and maybe get a D dimer, although they didn't give you that as a choice. And I think their rationale is if you use the cheaper resource, maybe you'll find some right heart strain on ECG, or maybe the rare S1Q3 T3 finding on there and see, and then that might lead you to do a CTP, or if you have a D dimer that's normal, maybe you don't have to do a CTP. Okay, but then I mean I kind of recall these studies where people with acute exacerbation of COPD are at risk of having incident PE. 16% on this emergency medicine study in 2016, 2017 chest. I'm not going to go into details. I don't know these studies, in depth either. And then the most recent one was 6% prevalence found in JAMA 2021. That was the largest study to date, where they did a multi-center French study. It enrolled 740 consecutive patients that were admitted with COPD exacerbation. They followed this very strict algorithm using Geneva scored, another stratification score, D dimer, CTPA, light compression, if those were indicated, and found the prevalence of PE in those patients about 6%. So I don't know. I would, I would have picked A. I don't know. What's your take on this, Tom?
This is one of these answers, one of these questions that you would never actually see on the boards because there are too many answers that too many of the options could be potentially correct. I think the teaching point of this, and you sort of talked about it, Ken, is that ACS can frequently present as a acute exacerbation of COPD, and a cheap, quick study to perform when somebody is presenting with an acute exacerbation of COPD is an ECG. And I think that would always be the first step, right? Before you send somebody to a CT scanner, before you got labs, you would get an ECG. So, and I think that is what is the point of this question and why they are saying that is the right answer. Because it can, as you pointed out, help differentiate if something else could be going on. Like there may be a S3, Q3, or I'm forgetting it, but I'm forgetting the acronym. But there might be a right heart strain pattern on your ECG that may point you one way or the other. There may be T wave changes. There may be ST segment changes that could make you think more that this is an NSTEMI or a STEMI. So, I think that an ECG is a low risk intervention, and which is why it's the right answer here. The other part of the question stem, if you go back to it, that sort of argues against this being a pulmonary embolus based on history alone, and some of the studies that they obtained. So patients who typically present with pulmonary embolus as an exacerbation of COPD don't usually have they don't have changes in sputum, and they usually don't have increased wheezing. They typically present with just increased dyspnea, which makes sense, right? Because the PE is causing an increase in their dead space, and it's causing them to have to ventilate more in order to meet their ventilatory requirements, making them breathe more to meet their ventilatory requirements, which is why they feel more dyspneic. And the one part about this question stem that argues that this is not a pulmonary embolus is the fact that this patient is not hypercapnic in particular. I think that, classically when you're going to see a board question about a PE in a COPD patient, they're going to have an acute hypercapnic respiratory failure because their respiratory muscles just can't keep up with the work of breathing and can't blow off that excess CO2 because of that increased dead space from the PE.
Great, thank you for those helpful pearls. Okay, I'm gonna move on to the next one. So this is question 3. Okay, a 49-year-old woman is evaluated in the office following a recent hospitalization for an asthma exacerbation. Her symptoms have improved, but she continues to have dyspnea and intermittent wheezing. She has had 2 other hospitalizations within the past year for asthma exacerbation, despite chronic use of oral glucocorticoids. Other than a 3-year history of asthma, her medical history is unremarkable. Medications: mometasone and formoterol, montelukast, albuterol, tiotropium, and prednisone. On exam, vitals are normal, saturation 95% in ambient air. Pulmonary examination reveals expiratory wheezes with good air movement. The rest of the exam is unremarkable. Her labs show a white count of 10,000, 650 EOs. Serum IG is 12, which is within the normal range. FEV1 is 56% of predicted. Chest X-ray is normal. Okay, here's the question. Which of the following is the most appropriate treatment? Okay, so C is the most popular choice, 92%, and D was the runner-up at 8%. So this is how the overall people doing MKSAP answered. Okay, so we're doing pretty good as a group. Maybe we don't even need to do this. And so initiate trial of mepolizumab. So I think for me, well, the other top responder was omalizumab. So getting these monoclonals mixed up. So that's my thought is that, and I'll query Tom. Well, let me go back. So 12% also picked changing the inhaler formulation as well. Okay, so questions I pose: are there differences in inhaled corticosteroid formulations? Here's some stuff I dug up. Well, if you look at asthma treatment guidelines, there's low, medium, and high potency dose that you give, like 2 puffs a day of the low dose, 2 puffs a day of the high dose, etc. And then, so I guess my questions to Tom is that, is there a true difference? I mean, I'm looking at these glucocorticoid binding affinity. So in relation to our patient, you're talking about she is on mometasone, which actually has a higher binding affinity to fluticasone propionate, which was the question asking you to switch her to. And is there huge differences between dry powder and propellant MDIs?
This is a controversial topic, highly controversial topic, which always makes it the wrong answer on a board exam. What I would say is that the steroid itself, so whether it's fluticasone or mometasone or beclomethasone or cyclosinide or budesonide, the steroid itself does not matter. If you give a patient an equipotent dose of the steroid, it will work equally effectively. There is some literature, particularly preclinical, that suggests that small particle size for patients with asthma with significant airflow obstruction is more effective at reaching the distal airways than the dried powdered formulations, because the dry powder is a larger molecule size and it will get deposited in the larger airways before it reaches the terminal bronchioles. There are true believers that say that the HFA is more effective than the dry powdered formulation for patients with severe asthma with airflow obstruction, like fixed airflow obstruction. There was a meta-analysis in 2017 that was published in the BMJ that disproves this for all comers. And they actually looked at clinical studies that compared the HFA versus dry powder formulations, and there was no difference in symptoms, exacerbation risk, or quality of life. So the true believers are going to tell you that they looked at all comers and didn't look at the small subsegment of patients with severe asthma, and that's why that was a negative study. The short answer is, on a board exam, all steroids are equivalent.
Got it. All right. Well, move on to the next slide. And then this is kind of hone in on the fact of which monoclonal do you pick. And I actually learned quite a bit about putting together this lecture myself, and just looking at different types of asthma phenotypes. And I'll just pull the slides up and I'll let Tom take over. And this is a little table I created on, what's available, what's approved on the market. I mean, the only thing I learned in school was omalizumab. That was the only one that was available at the time. And I think a bunch of these popped up in the last few years. And I'll kind of let Tom drive this next part and talk about this a little bit more detail. Yeah,
so omalizumab actually has a very narrow indication. Because it is an anti-IgE therapy and works by depleting IgE, you have to have enough IgE circulating in order for it to be effective, but you can't have too much also, because if you have too much, you're not going to be able to deplete it and you won't have a clinical benefit from the treatment. So that is why the clinical trials and the FDA approval is for serum IgE levels between 30 and 700 international units. So it has a very narrow therapeutic indication. The other part of the question stem that will be incredibly important if you're going to say that omalizumab is the correct answer is that patients also have to have allergen-specific IgEs, and they have to have clear history of exacerbations or triggers from environmental allergens. Otherwise, it's not really indicated and is not effective. So then that brings us to the anti-IL-5 therapies, which is probably probably the sort of game-changing medication for allergic asthma. And the first three in the table, the benralizumab, mepolizumab, and reslizumab, are considered to be equivalent in terms of their efficacy. If you look at clinical trials and you look at FDA approval, you should consider this whenever somebody has an absolute serum eosinophil count greater than 150, although the greatest clinical benefit is among patients with an absolute eosinophil count greater than 300. And the benefit is really to reduce exacerbations. People have a 50% reduction in their rate of exacerbations with anti-IL-5 therapy. And then the newest comer is the dupilumab, which is an anti-IL-4, and it similarly is indicated for people with eosinophilic asthma greater than 300. And these patients can have both a symptomatic improvement as well as the 50% reduction in exacerbations.
Got it. And I think going back real quick, our patient had a EO of 650, right? So,
yeah. And the serum IgE level is probably the lowest that I've ever seen in a patient with asthma.
Oh yeah, 12. Okay. So that's a huge. I mean, 50% reduction. Do they have to be maximized on all available non-monoclonal therapies before you can start this?
Yeah. So all of these patients in these trials were on high dose inhalers. Many of them were on a long-acting muscarinic antagonist as well. So these are patients with severe asthma who are refractory to other treatments. Many of the patients in the studies were also on oral glucocorticoids.
Got it. Okay. So of course, price is another thing to consider, right, with these. Okay. All right, question 4. 58-year-old man with a history of severe COPD is evaluated for his chronic exertional dyspnea. He's taking inhalers and medications as prescribed with excellent technique and has completed a pulmonary rehab program within the last 6 months and is continuing the exercise program. He's using supplemental oxygen, but despite adequate oxygenation, still has significant exertional dyspnea. Current medications are umeclidinium and bilanterol, mometasone, and albuterol. He feels that his current quality of life is poor, would like other treatment options. On exam, vitals are normal. He's satting 90% on 2 liters. The BMI is normal. Pulmonary examination reveals decreased breath sounds throughout with a prolonged expiratory phase, but without wheezing. Spirometry demonstrates severe airflow obstruction. A recent CT chest shows heterogeneous emphysema without any nodules. And a recent echocardiogram shows diastolic dysfunction, but no evidence of pulmonary hypertension. Right? Which of the following is the most appropriate management? Next step. Okay, so here's our response. 69% chose roflumilast in the last, and then there's a split 14-17 from B and C. Okay, so I will say I made the same mistake. I picked roflumilast as well when I did this, and I just remember this medication. It's like, yes, you add it for people with exacerbations, just like azithro, but I think they're quite different actually. We'll look at that. And so lung volume reduction evaluation is the correct choice here. Why that is, so here's what I dug up, and Tom can share his expertise on this. So in terms of roflumilast, it's a PDE4, it's an oral PDE4 inhibitor. It's got an anti-inflammatory effect. So for my reading, it's mostly for patients with bronchitic symptoms and frequent exacerbations rather than this chronic dyspnea. And you do need to watch for kind of weight loss, GI symptoms, and mood changes. We'll take a pause right here. I'll jump over to Tom and his experience using this medication.
I would say that none of you should prescribe roflumilast in your primary care clinic. It is a medication that has a very narrow indication. As Ken pointed out, it's really only for patients with prior smokers, so former smokers who have chronic bronchitis symptoms, so daily sputum production, with frequent exacerbations. It's not really indicated for patients with emphysema, not really indicated for patients with dyspnea only, and it is very poorly tolerated. The majority of patients who get started on it stop it because of diarrhea and weight loss. So I would say that this is never the right answer. You should consider other medications before considering roflumilast.
Got it. Ugh, not very pleasant. Doesn't sound pleasant at all. So, well, why is the other one the right choice? The lung volume reduction surgery. I think what threw me off when I was looking at this question is this heterogeneous emphysema, and I'm thinking, hey, wouldn't it be better if he just had emphysema all in one spot and you just remove it, excise it, and feel better? But actually, it turned out not to be the case. Looking at the candidate selection for lung volume reduction surgery. Anyway, so I will. So it looks like it's pretty hard to get a patient to have this, but it does increase dyspnea exercise capacity. And the largest trial to date, correct me if I'm wrong, is the NET trial, the National Emphysema Treatment Trial. It's published in 2003, and this is what I've dug up on indications and contraindications. So I guess my question is, how many patients actually get this, and does it make a huge impact from your experience, Tom?
So it is uncommon for patients to meet the criteria, the inclusion criteria for the surgery. Patients have to have upper lobe predominant emphysema, and on a PET scan show that there is minimal blood flow to those areas. The whole purpose of lung volume reduction surgery is to, as it says, decrease the total lung capacity and decrease the residual volume. So essentially fix air trapping and optimize the respiratory muscle function by decreasing the size of the lungs and putting the diaphragm into a more favorable position, a more natural position. There are a lot of exclusion criteria. The biggest exclusion criteria is actually any degree of pulmonary hypertension, and most patients have to undergo echocardiogram and then a right heart catheterization prior in order to exclude pulmonary hypertension, because again, you're removing part of the pulmonary vascular bed, and even though there's very little blood flow in theory to the area of the lung that's bullous and very emphysematous, patients with mild pulmonary hypertension can develop severe pulmonary hypertension after the lung volume reduction surgery. So you're absolutely right, Ken. This is a very uncommon treatment, but it is a highly effective treatment for patients who meet the inclusion criteria, and it can be life-changing. Patients can have significant improvement in their exercise capacity and significant improvement in their dyspnea and quality of life. So it is something that I definitely would consider for patients who have predominant dyspnea and have, as you pointed out, heterogeneous emphysema, but it's the real correct way to describe it is upper lobe predominant emphysema on their imaging. I will put a plug for what I do. Lung volume reduction surgery makes lung transplantation very challenging because it creates pleural adhesions and scarring, and usually patients are only a candidate for one or the other. This was not an option in your question stem, but a correct answer for this patient would also have been referral for lung transplantation.
Got it.
There's a question in the chat, just and you may have answered it in what you were talking about a moment ago, but Sarah asked, our group was under the impression that lung volume reduction was more common for the upper lobe predominance. The group thought that this patient presented with diffuse emphysema. And so I don't know if you wanted to comment on that.
That is an absolutely correct comment, although many patients will have emphysema everywhere. It's just that there is more emphysema in the upper lobes. Because it's very common for patients to have emphysema in the lower lobes as well who undergo this surgery. It's just that it is more concentrated and worse in the upper lobes.
Got it. Okay. And so, well, we don't know what this patient is based on the question stem, but the red dots, at least he meets the first 4 criteria. So just brief about traditional techniques. You can do a thoracotomy or a thoracoscopy with wedge resections. You can do one-sided versus bilateral. And I guess this was the newest thing I found. I think it's been around for a few years, right? Where you can endobronchoscopically deploy these one-way endobronchial valves so that you can prevent air trapping, and that the air comes out, but you can't get more air in. So just essentially occluding off parts of the lung. Do we do that here? Is it advantageous? I don't know if there's been studies comparing traditional versus endobronchoscopic.
Yeah, so endobronchial valves are actually in randomized controlled trials considered to be equally effective to lung volume reduction surgery at improving symptoms and quality of life. I think the challenge with endobronchial valves is that similar to lung volume reduction surgery, the indications and the patients who meet criteria for them it's a very narrow segment of patients with COPD. In order for an endobronchial valve to work, the lobe that you're putting the valve into has to not have any pores of cone in them. And that's a pore, it's a connection between the alveoli and between different lobes of the lung that allow for collateral ventilation, which makes sense, right? Because if the patient can collaterally ventilate through a different lobe of the lung and you're only blocking off one of those airways, the valve's not going to work. That lobe has to be isolated from the rest of the lung. And only about 20 to 30% of patients will meet that criteria, actually not have the pores of cone be patent and have the lung be completely isolated where you're putting the valve. So unfortunately, it is not a very widely available intervention, which is why we don't do it very often.
Got it. So it's like a subset of a very narrow group of patients. The question, presumably, if you use one of these valves, would that not exclude you from lung transplant, since you won't get the scarring, I assume?
Yep, that's a very fair point. These valves definitely could be a sort of option for patients who want to consider lung transplantation moving forward. I will say that one of the biggest problems with these endobronchial valves is not only the narrow indication, but also a lot of patients develop pneumonia, like a post-obstructive pneumonia behind it, and end up having to have them removed because they have recurrent pneumonias. So it's not a silver bullet. It's not a perfect treatment.
Got it. All right, the last Pulm question. We have a 72-year-old woman evaluated during a routine visit. She's a 30-pack year smoker, quit 5 years ago. She has a history of mild COPD and breast cancer diagnosed 15 years ago, currently in remission. Chest radiograph from 5 years ago showed no signs of disease recurrence related to breast cancer, and she's on albuterol and tiotropium. On exam, vital signs are normal. Lung exam reveals prolonged expiration and diminished breath sounds throughout. The breast exam is unremarkable. Screening low-dose CT scan of the chest shows a peripheral 9mm solid pulmonary nodule in the left and left upper lobe and emphysema, but no mediastinal or hilar lymphadenopathy and no pleural effusion. PET CT is performed, and the nodule is intensely hypermetabolic. There's no evidence of distant uptake. Okay, so here's the choices. What's the most appropriate management or next step?
Ken, just as a time check, we have about 10 minutes.
Got it. Right, so most 79% picked surgical wedge resection, and then the most of the rest of the group picked transthoracic needle aspiration at 18%. So this was the MKSAP response rate. So most got it right, but 47%. So again, as a group, we did generally better. And I think for me, the key points, hopefully I didn't get this all mixed up. At least for me, the key points that this patient meets lung cancer screening criteria, right, based on USPSTF. And And then I guess my question is does Fleischner lung nodule criteria apply to this patient, and kind of determining the risk for malignancy in this nodule that you picked up. So here's the Fleischner criteria. I just snipped part of it that applies to this patient. She has a 9mm nodule. So here it says, well, assuming she meets Fleischner criteria, and Tom can comment on that further. I'm under this, from my reading, she doesn't, because she has a history of primary cancer. Would that be right?
Yeah, and although the history of the primary cancer is pretty remote,
Okay.
But at the same time, this is a nodule that was found as part of a screening CT scan for lung cancer, rather than an incidentally found nodule on a separate study. And the guidelines are a little bit different for that. This is a high risk lesion based on the history provided and the imaging characteristics. So I actually don't think any of these options are the right answer that are listed here. Like
Even for
consider
the question
CT at 3
choice.
months, PET CT or
Here,
tissue
okay.
sampling. Like the correct answer is to biopsy this
Got it.
or to remove
moving.
it.
Got it. So she doesn't fall into that. That's an incidental node detection sort of management algorithm. So she would fall into this lung RADS because she's using it for lung cancer screening. And then here I was just looking at, so she'll be like a 4A because the size of the nodule. And so then I guess, is it, well, you said, no, you shouldn't wait, right?
Yeah, so this
You
is
should
based upon, this outline is based solely upon the imaging risk, and you have to take in the clinical characteristics of the patient as well. When patients are seen in a multidisciplinary lung cancer screening clinic, which I strongly recommend you refer patients to if you're going to do lung cancer screening, they take into account clinical characteristics as well. And on the right-hand side of the screen here, assess the likelihood of malignancy is probably the most important aspect of this. And there are a couple of calculators that can help you to do that if you wanted to do it yourself. Probably the most common is the Brock model. There's also one out of the Mayo Clinic. And this patient's risk of malignancy is actually high based on the clinical history, the pack year smoking history, the fact that she's a woman, that actually increases her risk of this being a malignant nodule. And there's a couple of other characteristics about the nodule, the peripheral upper lobe predominant, all characteristic of lung cancer. So the correct answer here, particularly since you got the PET scan, is to resect it. I think if you hadn't gotten the PET scan, biopsy would have been reasonable. And then if the PET scan were negative, I think biopsy would still be the right answer, because a negative PET scan does not rule out malignancy.
Got it, because she saw it. There's such high pretest probability of having malignancy.
Exactly.
Yeah, okay. Got it. Okay, well, that kind of concludes the Pulm section. You might be able to get through one more question, hopefully, if John will allow. Okay. So here is we'll move on to the sleep side. So a 62-year-old, maybe I might fly through this. 62-year-old and man evaluated for sleep apnea, recently hospitalized for AFIB with RVR. He sleeps okay, but feels unrested and dozes off during the day while inactive. He's got a bunch of typical comorbidities, hypertension, diabetes, and he's hypertensive. His BMI is 29. He's got a low-lying soft palate, prominent tongue base. So he's got oral crowding, and he's got irregular heart rhythm. And so because of the AFib, there's a PSG that was done, showed moderate severity obstructive sleep apnea based on a AHI of 18. Anything over 15 would be a moderate severity, 15 up to 30, and the A1C 7.5%. And then, so what condition has the strongest indication for PAP therapy? Yeah, excessive daytime sleepiness. That's 79% response rate on that. That's the correct choice. MKSAP sort of answer is 56%. And why that is, well, I think this is actually not a well-written question because 3 of them are diagnoses, one's a symptom. But anyways, in terms of why that is the correct answer, we have the most robust data that CPAP improves sleepiness. Okay, it's been shown in multiple randomized controlled trials. It improves sleepiness and sleep-related quality of life. And with regards to the other items, hypertension, we have the best data in terms of patients with better data, not the best, but better data, especially in patients with refractory or resistant hypertension. This is run-of-the-mill mild hypertension on one medication like this patient. You're not going to see much benefit from CPAP. And medication is going to give a much greater benefit than CPAP. And then the other, the AFIB control, well, we just don't have data on that. I'll show you on the next slide. In that there's been a bunch of randomized controlled trials done. So observationally, observational prospective trials show that if you treat someone, sure, they have less risk of mortality, stroke, cardiovascular disease, AFib, but none of those have held up, unfortunately, on randomized controlled trials. And sure, there's some criticisms of the patients that were included in the trials, but I won't get into details of that. But so far, RCTs have not demonstrated any difference, PAP versus control, in terms of recurring, preventing primary or secondary cardiovascular disease, and including AFib. There's only been 2 recent randomized controlled trials, both very small, for seeing if AFib burden decreases or if risk of recurrent arrhythmia post ablation or cardioversion decreases, and haven't found the benefit. But again, one key piece to note is that all of these trials excluded non-sleepy patients. Sorry, they excluded sleepy patients because they felt that if we have a therapy that benefits sleepy patients, it would be unethical to include those patients in the trials. Okay. 71-year-old man.
No, that's fine. There was a request. I don't know which question this was. There was a request to hit the central sleep apnea question.
Oh, this is the one.
Oh,
okay.
Excellent. Thank you.
So a 71-year-old man evaluated during a follow-up visit for sleep-related breathing pauses observed by the hospital staff. So he's got an ICD for ischemic cardiomyopathy, EF of 30%. He recently experienced dyspnea, some episodes awaken him from sleep. He's got no insomnia. He's not sleepy. Key piece, he's not sleepy. And then, so he's on cardiovascular medications, on exam, 93% on ambient air for saturations, BMI is 23, again, so he's not overweight. And he's got some signs of volume overload. Polysomnography shows central sleep apnea with Cheyne-Stokes breathing pattern. Okay. So I think which of the following is the most appropriate treatment for central sleep apnea? Nice, Anisha. This is a tricky question, let's see, yeah. We got a pretty wide spread. So A got 30%, B got 39%, C got 24%, oxygen 6%. Very similar spread for MKSAP takers. Okay, the correct answer is furosemide, and I'll try to explain why that is. All right. So remember, the choices are ASV, what is that thing, and auto CPAP and furosemide. Okay. So here's the learning points. You're going to have a pretty high incidence of Cheyne-Stokes and central sleep apnea in patients with heart disease, especially heart failure with reduced ejection fraction. The underlying pathophysiology is that there's a circulatory delay, meaning that the blood flow to the head, to the carotid chemoreceptors is delayed, and because of just pump failure, whether it's AFib, aflutter, or heart failure. And then because of the circulatory delay, your chemoreceptors have trouble figuring out what the heck the body's CO2 level is. And because of that, it has trouble controlling the ventilatory response. So you get overshooting and undershooting of your CO2 levels, which leads to these hyperpnea phase and the apnea phase. Okay. And as I've shown in this picture here, which is Cheyne-Stokes breathing, it's actually Hunter Cheyne-Stokes. There's always a guy at the sleep meeting every year that gets really angry if you don't include the first person on there. But there's no best treatment for essential sleep apnea with Cheyne-Stokes breathing beyond optimizing the underlying heart failure. And because this patient has some fluid overload, you should diurese them. And yes, $2 medication, not a $1,000 machine. And ASV, it's actually $5,000 that machine. CPAP would be close to 1,000. So this is adaptive cerebral ventilation. It's a special device created to treat central sleep apnea with Cheyne-Stokes breathing. Then why the heck we don't? So what happens is that when you go into these apnea or hypopnea phase, you're not breathing as much. It gives you a lot of support, respiratory support, pressure support. And when you're in the hyperpnea phase, the machine doesn't give you any support on the bottom. And you probably can't see my pointer right here. So it just kind of matches your ventilation. So why don't we use it? It's such a wonderful thing. Well, we did used to use it until this New England article came out in 2015, and it showed that it surprisingly increased all cardiovascular all-cause mortality and cardiovascular mortality. Hazard ratio was a little bit over 1. And especially, so they enrolled patients with an EF of less than or equal to 45%. More specifically, patients had a stronger signal when they had EF less than or equal to 35%. And this patient has an EF of 30%. So from that point on, we stopped using ASV. And since then, there's no great options otherwise besides optimizing heart failure. Okay, but individual patients may respond to CPAP or non-supine sleep position or supplemental oxygen. CO2, there's a guy at Boston that likes to use CO2 by adding dead space by giving more tubing or kind of using Play-Doh to cover up half the mask, the vent on the mask, and acetazolamide, essentially to dampen your response to CO2. Okay. So I would, I'm gonna jump ahead. I just wanna show you this one last question and before the meeting, because we got a really low response rate on this question. Okay, here we go. So it's actually the last question, but 31-year-old woman evaluated for 1 year history of daytime sleepiness. She falls asleep watching TV, at the movies, and eating. She usually goes to bed at 10 p.m. to midnight and wakes up for work at 6 a.m. On weekends, she wakes up at 9 a.m. rather than 6. Her husband says she snores, but hasn't noticed any apneas. She has no cataplexy, restless legs, etc. Doesn't take any medications, is not overweight. The oral pharynx looks pretty normal. So it looks like a pretty healthy 31-year-old, besides is real sleepy. So what would you do as a next step? That would be you, I guess. I think. Sounds like a resident too. Okay. So B or C again. Well, C and D got the most response, 45% and 42%. So we want to do fancy tests, right? Remember, the choice is never a fancy test. So we've learned, look for the cheapest option. And the correct response that you all had 3%, the test takers had 6% on. So I just want to highlight this one so you don't, I think it's just that we don't know what is actigraphy. Well, I think we picked PSG because we're familiar that it's a sleep study and maybe this person has something going on, but actigraphy, you think of it as a fancy sleep diary. Essentially, it's like an iWatch or a Fitbit that tracks activity. In this patient, she's otherwise healthy. She snores a little bit, but they told you that she's not overweight. Her oral pharynx is not crowded, and she's got no other sleep symptoms beyond snoring. She does not need a sleep study. And multiple sleep latency testing is used to evaluate, objectively quantify the degree of sleepiness, such as if you're looking for a narcolepsy or some other sort of hypersomnia disorder, where they're actually given 5 opportunities during the day in 2-hour segments to take naps. And you measure how fast they fall asleep and do they hit REM sleep, which would be abnormal if they get into REM very quickly. So actigraphy, which is my last slide, is just a validated method of objectively measuring rest and activity cycles. There's a sort of a pedometer or a sort of a os gyroscope in there. And usually you wear it over 7 to 14 days, and the device captures light exposure and motor activity. And it can quantify, as you see on this graph, the blue parts are when the patient is asleep, the black specks are when they're moving around, and the yellow lines are light exposure. So this patient, the clue is that she doesn't get enough sleep on weekdays, and she makes it up on the weekends. So she just really needs to get more sleep, and you would find that out by doing an actigraphy. Okay. I'll shamelessly put a plug in. It's coming time to sign up for electives. If you're interested, we have a sleep thematic ambulatory elective. We had 5 residents rotate through in the past year. This was the past year was the first year it was available. So check it out. Okay.
So thank you both for the discussions. I think that I'm now going to avoid head cheese, and now I know what actigraphy is, so I appreciate it. We're going to take a break. Ken's going to be the next speaker. He's going to have his house staff meeting. Why don't we take a break till 10:45, and then when you're back, please turn on your cameras as usual. Thank you.